It's a very exciting time in immune therapy for myeloma. We know that myeloma patients have a couple of different areas where the immune system is not working well, and so it looks like to develop an effective immune therapy, we really need to target all aspects of that. We talked initially about the checkpoint blockade drugs, which include PD-1 antibodies. It looks like they're very effective in certain diseases, but in the setting of myeloma, they may need to be put in combination with other therapies that also repair the immune system. And we talked about in the context of our vaccine approach, we've been able to show that our vaccine expands myeloma immunity, expands the number of T cells that recognize myeloma cells, and appears to affect the minimal residual disease state and moving patients from partial to complete remission. The idea of combining that then with a checkpoint inhibitor is very exciting, and we have trials right now that have started looking at that particular question, showing again that there is a clear immune effect of putting these two approaches together. We're also going to be looking at this in the context of a national trial where patients who are going on to get a transplant and then lenalidomide maintenance are going to be randomized to get the vaccine or not to see what the long-term effect is both on their immune system and their ability to keep the disease away. I think there are many different approaches to this and different companies that have drugs that they're developing. The short answer is we don't know which particular agent is better than the others at this moment. There is clear single agent activity in certain diseases like Hodgkin's disease and melanoma. In myeloma, this may require, again, the addition of other agents such as IMiDs, like lenalidomide, or cellular therapy such as vaccine for it to be efficacious. I think the appeal of a drug like a checkpoint inhibitor is that it's a drug off the shelf like any other antibody that we have a lot of experience using. And so that's, in some ways, once you get used to the potential side effects and how to manage them, I think is very broadly applicable. Cell therapies, which have had real excitement behind them and efficacy, have always carried the potential hurdle of how to adapt this into a strategy that can be then disseminated to people all over the globe. And our trial actually is one step in that direction of bringing in multiple sites to work together to learn how to make the vaccine and then see how we can apply it in a multi-center approach. So I think while cellular therapies do have certain hurdles to them, if the efficacy is there, then we'll develop strategies of how to approach it. We have been very excited by the development in engineered T cells and the CAR therapies. How that will apply to myeloma, we're still learning, but there have been some tremendous breakthroughs in the setting of acute lymphocytic leukemia. How they may integrate with other approaches, and we've been actually excited to think about how vaccines and T cells may interplay as part of immune therapy. So that's really an exciting area, and I think we'll have to see as the data comes in what the checkpoint blockades and IMiDs do together, because I think that also may be a very powerful combination.